respiration because the respiratory and circulatory systems work closely together. Other factors that increase respiration include medications, smoking, age, gender, stress, and illness. Respiration should be measured when the person is at rest. Wait 15 minutes after any activity. People tend to control their breathing when they know that their breathing is being measured. If possible, observe the person's breathing without him or her noticing. The easiest way to do this is to continue counting respiration after taking the pulse. If you leave your fingers on the wrist and begin counting respiration, the person will think that you are still taking the pulse and will not try to alter his or her breath. Breathing in and breathing out counts as one respiration. Taking deep breaths or sighing is normal. Count respiration for a full minute to get an accurate picture of the respiratory rate. Normal respiration has a regular pattern. The breath is even, quiet, and effortless. When counting respirations, observe the depth of the respiration. Is the breath short and shallow or long and deep? Does the chest rise and fall on both sides evenly? Then check the rhythm of the breath. Is the in-breath about as long as the out-breath? Are there periods of no breath? Listen to the breath. Is it raspy, gurgling, or wheezy? Observe the effort it takes to breathe. Is it difficult, easy, or painful? The normal respiration rate for adults is 12 to 20 breaths per minute. Children breathe more rapidly. Older adults, especially at rest, will breathe more slowly. Report respirations below 12 per minute or above 20 per minute. Once a respiratory rate, pattern, and rhythm have been established, then any change in that pattern should be noted and reported to medical personnel. Blood pressure is the fourth vital sign. Blood pressure is the force that blood exerts against the walls of the blood vessels. This force is caused by the heart pumping blood into the arteries. When the heart contracts, that pressure is called the systolic pressure. It is always the higher number in a blood pressure reading. When the heart is resting and filling with blood, there is less pressure against the arteries. This pressure is known as diastolic. It is the lower number of a blood pressure reading. An average blood pressure reading is 120/80, but readings vary depending on different factors, such as race, age, gender, fitness, illness, medications, smoking, bleeding, and acute pain. Normal blood pressure range is between 100/70 to 140/90. Exercise can temporarily cause a rise in blood pressure. Wait 15 minutes before taking a blood pressure reading. To measure blood pressure, you need two instruments, a stethoscope and a sphygmomanometer. The sphygmomanometer is commonly known as a blood pressure cuff. It has four parts: an inflatable cuff, a valve that controls the air that goes in and out of the cuff, the bulb that is squeezed to allow air into the cuff, and a dial. Using too small or too large a cuff can give a false reading. Blood pressure cuffs are available to fit a larger or smaller arm. If you are just learning how to use blood pressure equipment, there are several activities that will help you to become more skilled. To become comfortable with the cuff, practice wrapping and unwrapping it around someone's arm. To become more skilled with pumping and releasing the air from the cuff, practice with the cuff on a used plastic soda bottle that is filled with water. One of the first things to learn is how tightly to close the valve with the same hand that you used to inflate the cuff. Notice that if you close the valve too tightly, it is difficult to open. Then practice the speed at which you release the air. If you release the air too quickly, it is difficult to read the dial. And if you release the air too slowly, the cuff pressure can be painful and may even be harmful to the person. This dial shows the appropriate speed for releasing the air, which is 2 to 4 millimeters per second. The third skill you need to practice is reading the dial. The dial shows numbers from 0 to 300 millimeters. Each line represents 2 millimeters. For example, this dial reads 120/80. This dial reads 164/86.
Listening is another skill you need to develop. When listening through the stethoscope, sometimes you'll hear sounds like the tubes touching each other, or you might hear the diaphragm hitting against the cuff. The sound of the blood pressure is an even tapping sound, so you need to learn the difference between the two. Because blood pressure varies from person to person, it's important to determine the amount of air to inflate into the cuff. For someone who has a high blood pressure, you need to inflate the cuff above the systolic reading. And for someone who has a low blood pressure, you don't want to inflate the cuff too high because it can be harmful to them, especially someone who is frail and elderly, or it can also be painful. So there are 3 ways you can determine the amount of air to inflate the cuff. One is to just simply ask the person, what is their blood pressure? What's your normal blood pressure, Kay?
About 120/80.
Okay, so if her blood pressure is 120/80, then you'll want to inflate the cuff to about 150. You'll want to go about 30 millimeters higher than her average reading. You can also determine that by simply looking at the flow sheet and finding the average reading on the chart. Another method is to inflate the cuff to a moderate number, and a moderate number would be 140 millimeters. So you inflate the cuff to 140, and if you should start to hear the tapping sound, then you know you haven't inflated the cuff enough, and you want to inflate it another 30 millimeters higher. If you do inflate the cuff to determine the sound, it's important to take the cuff off and let the arm rest again before you take the blood pressure to get an accurate reading. The third and most accurate way to determine the amount of air to inflate into the cuff is to find the radial pulse. Once you find the pulse, then inflate the cuff until you no longer feel the pulse. When you no longer feel the pulse, look at the number on the dial, and then you'll need to add 30 millimeters to that number. For example, if the radial pulse could no longer be felt at 100 millimeters, then I would add 30 millimeters to that number. The amount of air to inflate the cuff would be 130 millimeters. Before you begin to take a blood pressure, eliminate any background noise such as TV, radio, fan, or heater. Always wash your hands before beginning the procedure. Gather the supplies you will need, such as the blood pressure cuff, stethoscope, disinfectant wipes, paper, and pencil. Clean the stethoscope and diaphragm with a disinfectant wipe. Explain to the person what you are planning to do. The person should be sitting comfortably or in a reclining position. Then uncover the arm that you will be taking the blood pressure on. If the arm is injured, paralyzed, has a cast or an IV infusion, do not use it to take blood pressure. Avoid taking blood pressure on an arm that has had surgery or if a breast has been removed on that same side. Adjust the arm so that it is level with the heart, palm side up. Remove any air that is left in the cuff by opening the valve and squeezing the air out. Then close the valve. The pointer on the dial should be at 0. Wrap the cuff around the arm about 1 inch above the elbow. The arrows on the cuff should be pointing toward the brachial artery that is at the inner side of the elbow. The cuff should be secure, even, and not too tight or loose. Place the dial on the cuff or in a place where you can read it easily. Put the stethoscope earpieces in your ears. Place the diaphragm of the stethoscope on the brachial artery that is located at the inner side of the arm. Inflate the cuff to the appropriate number. Keeping your eyes on the dial, deflate the cuff slowly by turning the valve counterclockwise. Listen closely. As the dial begins to drop, the first sharp thump you hear is the systolic pressure. Note the number on the dial and remember it. Keep listening and reading the dial as the pointer continues to fall. The last thumping sound you hear is the diastolic pressure. Remember the number so you can record it later. Allow the remaining air to escape from the cuff. Remove the cuff, leaving the valve open. Then record the blood pressure reading. The systolic pressure, which is always the higher number, is recorded above the diastolic and is separated by a slash. Clean the earpieces and diaphragm with a disinfectant, then wash your hands. Report any blood pressure reading that is not within normal range or is changed from what is normal for that person. If you do get an abnormal blood pressure reading, then take the reading in the other arm as well and report the pressure for both arms to medical personnel. Sometimes when taking a blood pressure, you will hear the beat all the way down to 0. When that happens, you need to listen for a subtle change in sound. When that subtle change in sound occurs, that will be the diastolic reading.
Record the pressure in this way. The systolic pressure is the higher number and is the first sound you heard. The diastolic pressure, or the lower number, is where the quality of sound changed. And 0 is when the last sound was heard. Electronic blood pressure devices measure the blood pressure without the use of a stethoscope. They are especially helpful for people who wear hearing aids or are hard of hearing. A display shows the reading. Electronic blood pressure devices should be recalibrated according to the manufacturer's recommendation. To assure accuracy, check the readings you obtain from an electronic blood pressure unit with those taken at the doctor's office.
Pain can affect us physically, as well as mentally, socially, and spiritually. Pain control is very important to our health and well-being. That is why pain assessment is recognized by many as the 5th vital sign.
Well, I feel that it's important to assess pain because unrelieved pain can be harmful to the body on many levels. Physically, it can interfere with healing. You know, if a patient has an infection that they're trying to get over, it can slow healing. It actually can make blood pressure be higher if somebody's in pain, and psychologically, or one thing that it can do is it can add to making a patient feel more anxious and depressed. And then spiritually, it can be the patient can question what they did to deserve such pain.
Some people, especially the elderly, do not relate to the word pain.
Rather than use the word pain, ask the person, do you hurt anywhere? Do you ache? Or are you uncomfortable?
Pain scales are helpful tools for assessing pain. Explain how the scale works so that the person knows how to rate his or her pain level. The numbered scale shows that at 0 there is no pain, 5 would be moderate pain, and 10 is the worst pain possible. The FACES scale works in a similar way, with the smiley face meaning no pain, the slightly turned down mouth is more moderate pain, and the very sad, grimacing, and crying face is the worst possible pain. Older adults often relate to color, and the thermometer scale may work best for them. The lower the degree and the color blue means no pain. The higher the degree and the redder the color means the worst possible pain. For those with vision problems, enlarge the scale for better vision. Try to find the pain scale that works best for that person and continue to use the same one each time.
It's really important to believe what the patient tells you. That's the gold standard with pain assessment, is that pain is whatever the patient tells you. And sometimes that's hard to believe, especially when they give you a number that's quite high and it looks like they're very comfortable. It could be that they're very comfortable because they're holding themselves very still, and when you go to bathe them and have them turn, then they show behaviors that they're really hurting. Also with chronic pain, patients oftentimes can look quite comfortable and normal and still have a very high rating.
Culture influences how we perceive pain. Admitting to pain is a sign of weakness in some cultures.
Different cultures may have different beliefs about expressing their pain. For example, if you're asking them if they're in pain or hurt anywhere, they may look at you and act very stoic. And so there are ways of assessing their pain even if they don't admit that they have pain. And that would be watching their behaviors. If they're in bed, looking to see if they're grimacing or groaning or holding themselves very still. For some patients, they look like they're fine and perfectly comfortable until you need to go ahead and turn them. And then that's a key time of watching to see if they're uncomfortable.
Your observation is key in determining whether someone is in pain or not. Observe the person during movement as well as when sleeping. People who hide their pain when awake may grimace or moan during sleep. It's important to observe for at least 3 to 5 minutes. People with Alzheimer's or related dementia or those with speech disorders may not be able to tell you when they are in pain. Common signs of pain include a furrowed brow, tightened lips or clenched teeth, flushed or pale face, a frightened look, tense or rigid body, bracing, clutching or holding on to things, restlessness, fidgeting, or rubbing the affected area. The person may groan, gasp, whimper, or sigh when you try to move him or her. The person may scream or curse, or say, "Stop it! Quit that!" Pain can also affect a person's vital signs. Record the pain scale rating on a flow sheet so that any patterns of pain can be identified more easily. Record your observations, including behaviors and physical signs of pain. Report any significant changes in comfort level to the doctor, nurse, or your supervisor. Any sudden pain or a rapid increase in pain should be reported immediately. Even though weight is not one of the vital signs, weight can provide valuable information for the doctor or nurse. Many medication dosages are based on weight, and a significant weight change, whether gain or loss, can cause medications to be less effective. Rapid or even gradual weight loss or gain can be associated with illness. For example, the first symptom of cancer is often weight loss. Signs that may indicate weight loss or gain are a change in appetite, or the fit of clothes and rings. Puffiness in the legs and ankles, or dimpling of the skin may be a sign of weight gain. Always weigh the person at the same time of day, on the same scale, and with the same or similar clothing in order to get an accurate measurement. Record weight on a flow sheet and report any patterns of weight loss or gain. Always take vital signs when you observe a change in the person's condition, such as a change in appetite, energy levels, behavior, or elimination. All the vital signs should be taken at the same time, because a change in one will usually affect the others. Vital signs are an important part of healthcare and should be taken seriously. It takes time and practice to learn the procedures correctly, and with practice, you will become efficient, accurate, and confident.